Hello, everybody. I'm Dr. Al Hewer. I'm a professor at Rutgers School of Health Professions. I co-edit Egan's Fundamentals of Respiratory Care. I'm a lead therapist at Morristown Medical Center in beautiful Morristown, New Jersey, which is kind of mid-upper portion of the state. And I'm co-owner of A&T Lectures with Terry Shenfield. Today's presentation for the next 50 minutes or so is going to focus on an update on medical errors and patient safety initiatives. So some of the short list, if you will, on objectives for this session, looking at the impetus for reducing medical errors, some of the organizations committed to improvement within this country, common causes of medical errors, some of the improvement initiatives that many of you are probably familiar with, the specific tools that we can use, and like I like to say with all of my presentations, to provide you guys with additional resources if you want to drill down and learn more about these topics. So one of the things that I'm intrigued about, and actually when I was pursuing my PhD at Seton Hall University, I was intrigued about all of the attention that was paid at a macro level. So I'm really talking about organizations that I'm going to be talking about today, like Centers for Medicare Medicaid Services, the Joint Commission, the Leapfrog Group, that you have all of these, the Agency for Healthcare Research and Quality, et cetera, policymakers, so the actual, the executive branch, president, the congressional branch, et cetera. They've all been involved. Okay, even the Supreme Court with whether should we strike down the Affordable Care Act, should we not? Should we look at different parts of it? Whatever. I'm intrigued. There's a lot of attention at a macro level, and then there's us. Okay, there's us. There's us that are providing bedside care, or the management team that's supporting the individuals that are providing direct patient care. And does what's happening at the macro level, does it trickle down to the bedside? By the way, it undoubtedly trickles down in some manner, okay? But are things lost in translation? Because we have all of these agencies and organizations that are dedicated in part or in total to quality. There's no other developed country in the world that has as many organizations that are dedicated to healthcare quality. Does that mean that our healthcare is safer? I'm going to say to you that the simple answer is no. It's probably safer, but it's not necessarily safer than that of other countries that actually do not spend as much on healthcare nor spend as much on healthcare quality. So let's talk more about this. So the impetus for improvement, not only is the impetus of improvement what I just mentioned to you, that we spend all of these resources, all this money in this country on healthcare oversight and quality, and you would think that we would lead the world in quality and outcomes, and we don't. We're like, if you took all the outcomes and threw them in a big hopper, we would be around 33 or 34. And then we'd be one step ahead of Costa Rica. And I have nothing against Costa Rica. I've only heard, my sister-in-law lives there. I've only heard beautiful things about Costa Rica. Okay, but it's a small country with a much smaller gross domestic product. No comparison. So we're in the 30-something ranking, but we spend more than any other country by a large margin. Okay, so that's one of the motivations. The other impetus for improvement is that there's multiple reports questioning healthcare safety in this country, and there's one in particular that came out in 2017 that basically said that that medical errors are the third leading cause of death in this country. We're talking about healthcare related death, diseases, things along those lines. Okay, to think about that. So there's multiple reports questioning healthcare safety, governmental concerns and regulations in response to that, demand of third-party payers. So CMS, Centers for Medicare and Medicaid Services, and I'll talk a little bit more about them. Okay, they're the biggest, if you want to call them, insurance company. They're a governmental insurance company. Okay, and they have what's called the value-based purchasing program. They look at these different metrics, and they will reward, if you will, healthcare providers, hospital systems, et cetera, that provide a higher quality care. Increased focus on patient welfare and ethics, increased competition amongst healthcare providers. So you can go online, you can actually check out, if you're having surgery on your knee, what place did the surgeon graduate in his or her class when they graduated medical school. And I'm not saying that's a prognosticator for them being a better or worse clinician, but there is a lot of information out there. One could argue maybe there's perhaps a little bit too much information. So some of the quality initiatives and quality issues, only about 50% of adults receive recommended care. This is all based on studies. 6 to 15 million injuries due to adverse events. So this was really what was formed the foundation for that piece that came out in 2017 that basically said, we made improvements, we still got a long ways to go. Okay, think about this. On average, 40 surgeries are still performed on the wrong patient, the wrong knee, the wrong shoulder, whatever the case may be. Okay, more than 80,000 centralized infections, resulting in about 28,000 deaths. Patient develops a concomitant sepsis, septic shock, they end up on a ventilator, blah, 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 and they don't do well. 70 to 190,000 deaths per year due to preventable errors. The social cost, it's not my calculation, social cost of all inpatient adverse events is between 350 and 900 billion. Okay, and at least one of 4 of these are preventable. So some of these agencies, I alluded to this earlier, agencies, organizations, some of them are governmental, some of them are not, committed to improvement. So they have these public, you have the governmental agencies, HHS, US Department of Health and Human Services, under which CMS, Centers for Medicare and Medicaid Services, FDA, it's the Food and Drug Administration, and the Agency on Healthcare Research and Quality, they all fall under HHS. So you have the private non-governmentals, the Joint Commission, used to be known as JCO, they're not known as JCO anymore, they're known as either TJC or the Joint Commission. Provider networks such as hospital systems, the Institute of Medicine that actually fund, but they also publish those pieces to Air is Human, Crossing the Quality Chasm, that were published, in the late 1900s and in the 2000s. Institute of Healthcare Improvement, the Leapfrog Group. Again, I'll drill down more on some of these. And then they have these combined efforts as well, the partnerships for patients that are really combined with patients with healthcare providers. Ideally, in a perfect world, it's a collaborative effort. You have public and private that are kind of, if you will, synergizing and producing enhanced bedside care. The reality is, okay, so the good news is this Venn diagram is saying, okay, you have the Joint Commission, and they talk to the Centers, CMS, Centers for Medicare and Medicaid Services. In fact, Center for Medicare and Medicaid Services actually looks to, one of the criteria to look for is the institution accredited by the Joint Commission. So there is there's some relationship there. The Leapfrog Group, in fact, looks, is the organization accredited by the Joint Commission. So there is some communication there, but they're not aligned. They're not in total alignment. There's some overlap. Okay, they're still separate entities that are kind of operating by and large in their own little universe. Food and Drug Administration. So some quick slides on who these organizations are. They look at the safety and efficacy of drugs and devices. They have a multi-phase approval process, which perhaps some of us are becoming a bit more familiar with, because some of the, basically you have your earlier phases. Phase 1 is it safe? It doesn't really have to do with efficacy or effectiveness. It has to do with, is it going to kill these patients or make them worse? Okay, so you have either animal studies or you have a very, very limited number of studies that are done on healthy individuals. Okay, did it not hurt them? Okay, and then you move on to like phase 2 and phase 3, where you're looking at small groups of individuals that actually have the disease. Did it make them better? And again, you're looking at it very, very carefully, looking at adverse events. And then you finally get into phase like 4, which would be like widespread approval, but they're still very closely monitoring, for adverse findings. Some of the recent issues that have occurred, warnings and naming labels of medications, so unit dose administration. Those medications are still troubling because some of those unit doses look very similar. The approval of COVID-19 vaccines, so you have emergency use, and now you have some of the producers that are now seeking full approval. Okay, but initially it was emergency use, so some of those, they went through phase 1 and phase 2, and then really phase 3. But phase 4 was not. It was saying we're going to continue to pursue phase 4, but we're going to release it. And it turned out it really looks like, even though you have a very, very, very small percentage of individuals that may have had some adverse effect, and I'm not talking about, when I got my second dose, It was a Sunday, middle of the day in January. The next day, I was not working at the hospital. I didn't feel great, and I'm old. Okay, so I'm at the time I was 62 years old. But I felt like, I didn't feel so great, type of deal. Apparently, some of the youngsters really got pretty sick from it, and I was at the hospital the next day and felt pretty decent. But again, you have varying stories, varying experiences. People that got the second dose and they were in bed for a day or two. So, just again, looking at those sorts of things very closely. Agency on Healthcare Research and Quality, actually known as ARC, believe it or not, even though the spelling isn't quite that, but known as ARC. So they promote quality in healthcare through direct and indirect support of outcomes research, evidence-based medicine, and best practices. So they let me just give you a concrete example. Okay, so I'm just got a piece accepted for publication in the Journal of Allied Health on use of simulations in various allied health professions, not just respiratory, by the way. We looked at them in lab. We looked at paramedics. By the way, FYI, paramedics use not in education, but in actual training of practicing paramedics. They're probably the biggest users. Respiratory is a pretty big user as well. So what I'm getting at is this. So the Agency on Healthcare Research and Quality funds some of the projects that look at the use of simulations to improve safety and quality. Okay, so for example, in my clinical world as a respiratory therapist, a respiratory therapy scholar, educator, blah, 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 there is what's known as the ASL 5000 lung simulator. Active servo lung 5000. Okay, that's what ASL stands for. It is the gold standard. Okay, in other words, you can emulate, moderate, mild, severe ARDS from the standpoint of lung compliance, et cetera, et cetera. So some of the studies that were used to validate the ASL 5000, to validate other simulators, not just in respiratory, in nursing, and elsewhere. A lot of that stuff is actually funded by the Agency on Healthcare Research and Quality. Just one of many concrete examples. And then patient safety networks, informational, consumers and patient guidelines, fact sheets, 5 steps to safer healthcare. They give. So it's helpful for us as clinicians, but ARC also produces information that's helpful to consumers, the patients and their families. So they kind of hit both ends of it. Even though if they're funding, simulator research, it can help patients, but that's really more in the theoretical part. They also produce, if you will, guidelines and protocols that are actually helpful to individuals. Recommendations for professionals such as us, patient safety primers, so adverse never events, and never events are events that should have never happened. Maybe they're just things that, somebody gets an IV and they get a massive gas embolism and they die. Things that just really never should have happened. The Institute of Medicine, I again briefly alluded to them earlier on, phase 1 in 1996. So then, basically looking at America's health in transition, protecting and improving quality. And then they came out in 1999 to Err is Human, where basically they said that, we have anywhere between 47 and 90 something thousand deaths a year. And they came out with this other series here, crossing. So how do we make it better? 2001, crossing the quality chasm. I'm not going to read this slide to you, but you can see, the bad news is we have problems. The good news is we're gradually making some serious progress, and other countries are emulating what we're doing. It's just taking a long ass time to get there. The Leapfrog Group. The Leapfrog Group is a consortium of over 150 organizations, really corporate organizations. So they represent over 34 million Americans. They're funded by the Robert Wood Johnson Foundation, as well as the Leapfrog Group members. So who are the members? They're basically corporate members. So think in terms of ExxonMobil, IBM, these huge, multinational corporations that basically say, listen, we're going to fund research. Okay. We're going to look at the other research that's funded by others. And based on outcomes, based on like report cards, we are going to, if you will, direct our business. We're going to direct our patients to organizations, hospital systems that provide high outcomes and high value care. So, quality care at a fair price. Again, it's not that simple, but kind of in that direction. Okay. Their mission more formally, is to recognize and reward safety, quality, and value in healthcare. So very consistent with what I just said. And a very simple mission. I'm actually teaching an online course right now in healthcare strategic planning as part of the master's degree that I also teach in at Rutgers. And we just got done evaluating mission statements, and this is really kind of says a lot in a very few words. Pretty strong mission statement. Support informed decisions, so evidence-based medicine, promote high value through incentives, promote the use of electronic health records and if you will, computerized physician order entry and other similar initiatives. Leapfrog recommendations, again, computerized order entry, evidence-based hospital referral. So we're directing that business to the hospital systems that provide the best care. ICU staffing, so an intensivist-led ICU. So you don't have different physicians coming in, seeing the same patient, and if you will, crossing lines. And just in other words, they're not talking to one another. So they're just like in their own silo. National quality forum safe practices, so create a culture of safety. They actually have a survey that's been validated. That is, Leapfrog Group uses a survey that's been validated by the Agency on Healthcare Research and Quality to examine culture of safety. Match the needs to the provider capabilities. So what they look at is things like, if there's 3 hospitals in a 10-mile radius and they all have cardiac catheterization labs, okay, and they all do cardiac surgeries, they discourage that. Maybe they all should have a cath lab, but they all should not be. They can't all, be diluting the volume, okay, and the specialty, the amount of investment that's needed. So what they basically would direct isn't the right word, encourage. What they would encourage these 3 hospitals to do is to collaborate and decide who's going to, you want to be able to, everybody treat a trauma, everybody treat an MI, everybody, but then who's going to specialize in cardiac surgery? Who's going to specialize in things like cancer care? Who's going to specialize in OBGYN, et cetera? So they kind of, and again, it doesn't happen perfectly, but at least to, make sure you're not all doing the same thing. Because we also know that one of the determinants of quality is the number of cases that you do. So we know that, you think about the learners, they don't have a lot of experience, so they tend to make more mistakes. Hospital systems that do a lot of cardiac surgery tend, over a long period of time, tend to be better at it, like a lot better at it. Improve the transfer of information, a whole nother issue there. I'm intrigued because I'm also a user of some of these electronic health records. I'm a huge fan, but if it's a teaching hospital, the resident physicians are now using it to replace, a closed loop communication. So they could be standing, some of them, or could be standing 5 feet away from you. They're putting an order that you need to know about in the system, and they don't even tell you. I'm putting an order in for an ABG. They just like walk away, and then, they think you're like Pavlovian, that you're the Pavlov's dog, that a little bell went off and you have a new order, and now you're going to go running, with bone in your mouth, whatever. It's amazing. Well, whatever. I think mostly positive or electronic health records, but devil's in the details. There's a few areas that, and I have some definite ideas along those lines, and I tend to share them pretty openly. It's a nice thing about being published and being old like I am. It's, you don't really, I do bedside care because I'd like to do it, not because I need to do it. So I can, how do I do? I have these teachable moments for the resident physicians. And we have some interesting exchanges. This particular slide is showing you, and it's dated, and it's dated for a reason, because I'm not trying to be a proponent of, Northbeth versus Overlook. No, that's not the reason for this. It is, you can actually go to Leapfrog Group's webpage, and you can see how they rate these various hospitals, okay, for various things. So it's not that, I'm big on, don't just use one source, don't just use a Leapfrog Group, but bear in mind, you can then go to CMS's Hospital Compare, okay, and they're going to rate these hospitals as well. So you can go to different sources and see how different sources rate these different hospitals. So something to kind of think about, both as a clinician and as a consumer. Joint Commission accredits greater than 90% of healthcare organizations. They have quality enhancement initiatives, survey standards. So about half of those survey standards target patient safety. They have what's called the sentinel event policy, targeting unexpected occurrence involving death or serious injury. So they have this reporting is encouraged. Root cause analysis is really, they want to see that as well. And then what's the plan that emanates? What was the root cause? And we're going to look at some cases at the end here, and we'll kind of talk a little bit more about the root cause. Patient safety goals and tracers. So the tracers have to do with, it's not a new practice, but it's a newer practice for the Joint Commission. And it really was in response to the fact that the Joint Commission, historically, going back, they were, I don't know if it was justifiably accused, but they spent a lot of time on process and structure and not a lot of time on how was the patient cared for. Not a lot of time on a surveyor going into a patient's room, ringing the call bell and see how long it takes for a response. Okay. And they've gotten better. They've really gotten better. Some of the, the bedside issues. So one of the ways they've done that is they use these tracers where they'll trace a patient from the time they're admitted, let's say through the ED, admitted to, step down, maybe they get escalated to ICU, and then they get de-escalated to back to the floor or to step down and eventually get discharged. And they look at every facet of their care. And they also look at it after discharge. So if the patient is an asthmatic or a COPD patient, did they get a referral? Were they considered for a pulmonary rehabilitation if they're a COPD patient? If they're cardiac, were they referred for cardiac rehabilitation? If they fit the criteria, that is. If they're a smoker, would they follow through for smoking cessation? Things along those lines. So now they really do. Joint Commission does it. It's commendable, actually, really kind of following more on, the overall holistic care of the patient and the entire, if you will, continuum of care. Some of the safety goals. So I'm giving examples here, not all of them, but communication. They recognize that communication is at the root cause of a lot of these problems. Therefore, it's something that really needs to be looked at. Reading back verbal orders. In 2004, they came out with the do not use abbreviations, where even though it's still used, cubic centiliter or cc is still used. It's not, you shouldn't use it, because sometimes a sloppy cc can look like two zeros. So it was problematic, where some, very rare occasions, a dose that was, 100 times the dose that should have been prescribed was prescribed. Reporting critical test results. Handoff communication through the SBAR, so having a consistent handoff as far as the issues that you're covering. Transfer, discharge, reconciliation. Then you have like bedside care, 2 patient identifiers. You're actually looking at the patient's wristlet as well as scanning it, recognizing, responding to the patient's conditions, preventing falls, the universal protocols, so pre-procedure timeout, verification. So even when we do a bedside bronchoscopy, there's a box we're checking for a pre-procedure timeout to make sure it's the right patient, getting the right procedure, et cetera. We have the right clinicians involved. Patient involvement as a safety strategy. So, patients are, they're involved at the center of the care. So they need to be, involved in the safety process as well. Some of the other safety goals: drug-related standardization of drug concentrations. The look-alike, sound-alike drugs are looked at very, very closely. Labeling of medications and solutions. And again, in my world of respiratory, some of the aerosolized medications still look remarkably similar to one another when they're out of the foil package. Med reconciliation. So that involves a whole lot of things, but one of the things it involves is if the patient's taking a medication at home, that the medication's either continued or we're aware that they're on it, but we've deliberately decided to take them off of their, if you will, their beta blocker because they're in a severe asthmatic condition, or to make sure that their Xanax is continued. They take it every day. It's not a good drug to take every day over a long period of time because it can be habit forming. But if you take the patient off too abruptly, they could have the exact symptoms that you're trying to avoid. If the patient is a smoker, so it's not exactly medication reconciliation, but if they're a smoker, that they're started on nicotine replacement when they're admitted to the hospital, and then they get the concomitant, nicotine and smoking cessation, counseling. Alarms, so maintaining a test alarm system. So, for respiratory therapists, that the ventilator is interfaced remotely. And for other life-sustaining equipment, that likewise, that there's a redundancy that's built in there, and that the alarm systems are tested. I'm big on checklists. I also teach a quality course, and I have created a checklist so that folks that are not in the ICUs, the adult ICUs often can just, I worked with a therapist yesterday who's per diem. He was helping me out in the ICU, and I gave him the checklist and said, so-and-so, glad to have the help and look forward to working with you today, but this is going to give you some ideas. If we get a new ventilator patient, we have to set it up. These are things we need to pay attention to as you're doing your vent patient checks, because I never call them vent checks. No, we're not checking a vent. We're checking an interface between a patient and a vent. But as you go and do those vent patient checks, we're making sure that the circuit doesn't need to be changed, that, that you're just checking a whole bunch of things. And then when you're all done with that, there's probably another respiratory therapist in the hospital who could use help. So I'm very big on the team approach. So let's try to find out who's in, let's voice area the person who's in charge and who can we help out. So that's on the checklist as well. When all else is set, take your break, by all means, hydrate, hit the bathroom, do what you got to do, but don't hide out. It's good for our profession to have presence. Back to the presentation here, Joint Commission safety goals, infection control, CDC, hand hygiene guidelines, understanding that, for certain conditions, as I referred to in my infection control presentation, that for spore formers, so for, Clostridium difficile, C. difficile, is that you don't use the alcohol, you vigorously wash your hands. Healthcare associated infections, so it used to be called nosocomial infections, that we're monitoring those very carefully and taking appropriate actions when there's an outbreak. So error-prone areas, look at the sentinel event program. It's called that because you think about it, sentinel events, one that requires intense focus. According to the Joint Commission, sentinel event is an unexpected occurrence involving death or serious injury. Examples, so unintended retention of a foreign body post-op. It doesn't happen often, it happens. Okay, my wife and I watch the show, The Monsters Within Us. It's mostly about like microbes and, different just things that start living in your body, that worms that invade your brain. Well, it's morbid crap, right? Well, one of them wasn't on any of that. It was on a patient who had a 13-inch retractor left in his abdomen and complained about it and said, I don't feel right. This doesn't feel right. And called into the surgeon said, no, it's normal. Went to another doctor. Doctor palpated, felt it, and said, this doesn't feel right. Came in X-ray, found out indeed there was a 13-inch retractor in his abdomen. How does that stuff like that happen? Thankfully, it's very, very, very uncommon, but it happens. Delay in treatment, so ER wait time, where maybe a patient with chest or abdominal pain is initially diagnosed or triaged with indigestion when in fact it's an MI. So it doesn't happen often, it happens. Wrong patient, wrong site, wrong procedure. Again, doesn't happen often, happens. Suicide, really talking about suicide on a patient who's high risk. So you got a site patient who's on suicide risk and maybe jumps out the third-story window. Happened in a New Jersey hospital about a decade and a half ago, 3 days before the Joint Commission was coming to visit them. The patient died. The patient jumped out a window, was on suicide watch. They did not stop them from getting from passing their inspection, but they had a lot of work to do. And it was, how did this happen? And there was a lot of subsequent reporting that had to be done. And it wasn't just about reporting, it's how can we ensure this never, ever, ever happens again. Post-op complication, the last bullet on this list or sub-bullet on this list, is an interesting one because sometimes complications happen. They're not necessarily errors. So, if you operate on enough patients, a few of them will develop, if you will, incision site infections. Doesn't mean that you made an error, but again, there's others that are clear, there's others that are gray area. Additional error-prone areas, so you have, medication error, wrong, late dose, falls, so you have bed rails left down, sedation holiday, maybe, they got agitated or maybe they subsequently sedation holiday, they were, the restraint was left off, wasn't tight enough, and then they pulled their endotracheal tube, their A-line, their ventilator-associated pneumonia or ventilator-associated events, VAP or VAE, monitored very closely. VAE part is, if you're increasing your oxygen concentration by 20 or more after a period of stability, or increasing your peak by 3 or more after a period of stability, it's what's called a VAE or a ventilator-associated event. Doesn't mean it's a VAP, but it means that the patient may be headed in that direction. Iatrogenic sores, so anything iatrogenic is, when I say we caused it, I don't mean us personally, but the patient came to the healthcare facility without it, and they developed it while they were there, while they're getting treated or assessed. Ulcers, wounds, so bedside sores, respiratory associated sores such as from a CPAP interface, resulting in breakdown on facial skin, things along those lines. The airway problems, so esophageal intubation. It's not just the esophageal intubation. It's going to happen, right? But it's prompt recognition of esophageal or a possible esophageal intubation, deflating the cuff, taking it out, and resuming, ventilating the patient. Okay, not leaving it in there, putting a bunch of air in the belly, then the patient vomits and the tube's in the wrong place, and now you got a what show in your hands. So it's not just the esophageal intubation, it's the lack of prompt recognition and response to it. It's really the key. Cross-contamination, COVID, we didn't see a lot of that. I don't want to say there was none of it, but we didn't see a lot of it, praise the Lord. Skin sore example, why focus on it? It gets a lot of attention because it was unfortunately common, it's highly preventable, can lead to other comorbidities such as sepsis. And as a result, as a result of the fact that it's avoidable, it's recognizable, all of these factors, it's often not reimbursed. So you have these different stages. Stage 1 is actually the skin is not broken. So it's the discoloration, the breakdown occurs beneath the skin. Again, not going to read this slide, but all the way up to stage 4 and unstageable. So it's not stage 5, but affects multiple layers of tissue, including muscle, bone. Problem with it getting infection in the bone, it's known as osteomyelitis. And when you get a bone infection, they're very stubborn. They're very, very, very hard to get rid of. And then you have a dark substance called eschar, may be present. Unstageable is, it's down. Ulcer may have a yellow, brown scab covering. The damaged tissue layers are extensive, requires debridement and removal, often multiple debridements. Root cause analysis here is your fishbone diagram, a tool that can be useful in doing the root cause analysis. And the root cause analysis is, how did this happen? What were the factors? And the reason why it has these components, the equipment, the process, the people, materials, environment, management, is because when these things happen often, it's the result of multiple issues lining up in the wrong direction to create the problem. So the debrief looks at these. It was the equipment that was involved. What was the process? Was the patient assessed when they came from the skilled nursing facility? Did they come to us with a sore that got worse, or did it develop here? Were they on a special bed? If it's a CPAP mask, they get a special CPAP mask. What people was wound care, when there was an index of suspicion, was wound care consulted? Okay, so you get the idea. Without beating this slide to death, you get the general gist. Pressure sores, or identify, again, the problem through the fishbone diagram. So, it may be, staff not aware of the risk or consequences. Many, many years ago, I've been a therapist for about 30 years, and I realize that some of you have been in, a nurse or an RT for much longer than that. Some of you less so. But when I first came into healthcare, if someone developed a sore on the bridge of the nose because of a BiPAP or non-invasive interface, it was a big deal. It was like, oh, okay, we'll just put a little stuff on it. We'll put a little thing with the other thing, we'll call a guy, we'll get wound care, we'll do a little bit of this, a little bit of that. Now it's a big deal. It was probably a big deal back then. We just looked at things very, very differently. Staff was not aware of, in this case, mask alternatives, bed alternatives, if it's a bed sore at the sacrum, the action plan. So consult with the wound care team. Basically, all hospital systems have wound care nurse or wound care team. Contact equipment manufacturers. Some of the, unfortunately, like there's a non-invasive mask out there. I'm not selling for anybody, but it's called the Amira mask. It is a wonderful device, but it's also wonderfully expensive. So a lot of these interfaces are, there's a cost that's associated with them. And there's a phantom mask out there. These gel masks are really, really good, but they tend to be a multiple. They tend to be 2, 3, 4, 5 times more expensive than some of the alternatives that are out there that maybe are more apt to contribute to skin breakdown. So research best practices, contact your fellow hospitals within your system and outside. You'd be surprised even how many, sometimes, my hospital system is Atlantic Healthcare. We collaborate with a competing system is St. Robert Wood Johnson, RWJ Barnabas. Okay. I know a lot of these people. We reach out to them. Hey, this is the issue we're having. How do you guys handle this? And vice versa. They reach out to us. you know, Terry and I have worked at University Hospital. There's a lot of back and forth and collaboration that happens, and it's totally appropriate. And it's a good thing that, you know, this collaboration takes place. Educate and reinforce. You know, I'm an educator, but I'm learning all the time, and it's one of the beautiful things that makes me a better educator, because I am learning all the time. I was in academic programs until I was, you know, well into my 40s. I finished my PhD when I was well into my 40s, and I was in school like all the time. So it's just, has made me a better teacher. And I like to say I'm still becoming a better teacher all the time. So it's a process. Revise and monitor as needed. Really, really important to be open to change, open to teachable moments. So the micro levels of cases in quality and bedside improvement. So, you know, this shows you a half a dozen clinicians that are collaborating on cases. You know, it's a little aged because they're actually showing you this. It looks like there's an x-ray that's laying on the table there. A lot of the stuff is digital today. But the point of it is you get this collaboration. Unfortunately, there's not a tremendous opportunity to do this, but I will tell you that, you know, one of the forms that physicians do this in is in terms of their M&M, their morbidity and mortality conferences. Okay, I will tell you that the hospital I work at, I'm on the committee for ventilator associated events and VAPs. Okay, and we look at each case. Okay, we really try to look at it in the context of we don't want the numbers to be crazy. We understand they're going to happen. Okay. And kind of part of the committee, it's not officially part. We also look at unplanned extubations. Okay, so it's not, you know, so we look at these things. We know they're going to happen. You know, there's going to be a certain number of these cases, but, you know, we're looking at them in the context of keeping the numbers to an absolute minimum and constantly trying to do better and better at what we do. Reviewing the latest that's out there, networking with, even again, you know, internally and externally with competing organizations, seeing what's on our professional association, you know, the American Association for Respiratory Care. They offer guidance on a lot of this stuff. You know, so the bad news is that these things happen. The good news is that there's progress that's being made, and there's a lot of resources that are out there. So let's look at some cases, and then we'll come down the home stretch. So the VAE bundle. So if a hospital or hospital system experienced an increase in ventilator-associated pneumonias and events, so look at the factors that may be correlated to it. Manipulating the vent circuit. So maybe there's been a change of equipment where now you're using, you're no longer using inline suctioning, or you've never used inline suctioning, you're breaking the circuit open, or you're putting a nebulizer in lines, you're breaking the circuit open, or you're changing, circuits 3 times a week, whatever the case may be. So you're manipulating the vent circuit unduly, okay? You're perhaps using particular airways that are more conducive to microaspiration, such as ones that don't do subglottic suction, okay? Endotracheal tube biofilm, where now some institutions are using what we call endotracheal tube scrapers or wiper caths, where they're actually, if you will, harvesting the biofilm, away from the patient, removing it from the tube, therefore reducing the risk that it's aspirated into the patient's lungs and contributes to, a ventilator-associated event, pneumonia, adverse event of some sort. Looking at increased length of stay, morbidity, and mortality, because the longer someone stays on a vent, the more exposed they are to lung injury, to infection, and those sorts of things. And looking at the pragmatic aspect of reduced reimbursement for these occurrences that are deemed avoidable. The action plan, looking at embracing the, if you will, the VAP bundle and raising the head of the bed. Mouth care, some of the latest data says that chlorhexidine there's not a good association between use of chlorhexidine and reduced incidence of VAP, but not a terrible thing to have good mouth care. Subglottic suction, something else you can look at. Daily awakening and spontaneous breathing trial, where you try to liberate the patients as soon as they're ready, not delay unduly. Desired outcome, the VAP and VAE rates are reduced. I would say eliminated, but I don't know if that's possible. Confusion regarding unit doses. So patient with albuterol allergy, actually what happened in real life was patient had a allergy to the preservative in it. And they were supposed to be given Atrovent, they were given albuterol, they had an anaphylactic reaction. They didn't die, by the way, they did not die. but their wheezing increased. They felt worse. Their chest tightened more. Okay, so it's like, how can we avoid these sorts of things? Tubing connection mix-up one, I have a couple of them in here, but the resident connects O2 tubing to an NG tube. What actually happened in this case, so I obviously changed some of this to protect the innocent, was that a patient who was on a med-surg floor had to go to the bathroom, and a family member, if you will, disconnected their NG tube from suction. They used the bathroom in the room. They came out, and the individual inadvertently took the oxygen tubing that was going to the nebulizer, connected it to what was supposed to be suction connector for the NG tube, and the patient felt like a funny sensation in the belly. They quickly disconnected it. They did call the call bell. So it wasn't a resident who did this one. Resident was involved in another one that we're going to talk about. But the moral of the story was, the individual factors. You actually had the family member, because there were signs all over. Make sure that you call if you need this stuff. If you have, even going to the bathroom, you need something connected, you're unsure. But you also look at how were these even remotely compatible, the connectors. Again, look at training of the clinician, because I obviously modified this case a little bit. How were they so unfamiliar with how things are to be connected, and what's connected to suction, what's connected to medical gas, and things along those lines. This one was a really tragic event, and it's not confidential. It was public. It was a hospital in New Jersey where it was a resident physician who connected O2 tubing to an IV and caused a massive gas embolism and immediate death. It's a 3-year-old. The nurse was in the room but had to leave briefly to check on another patient. The resident physician was in the room alone, as a clinician alone. There was a 3-year-old and a 3-year-old's dad. And as the resident physician was connecting the flowing oxygen tubing to the IV, the dad got half his sentence out and said, "Are you sure that gets connected?" Didn't get the whole thing out. It was connected. The kid's eyeballs rolled back in his head. He was dead. Gas embolism acts as a clot, and it was massive. So it actually happened. So you look at debriefing, human error was obviously involved, but how were these connectors even remotely compatible? The inadequate training of the resident physician, how was you look at, how was it so that resident physician was even able to be in the room alone and have the inadequate training? It was just these combination of variables. The action plan, the equipment, the connector switch, that happened, like they were no longer compatible as of like hours later. They were no longer compatible. Okay, intensive retraining. On Wednesday of this week, I'm actually participating in resident education, and the head of surgery tells the story. Each year he kind of puts a different twist on it, but the point of it is he tells this story of what happened. He tells it. So it's just an interesting, thing in the context of, let's not do this. Let's make sure that we communicate. Let's make sure we collaborate. Make sure we exercise humility. If we don't know something, we ask, and that sort of thing. Click stops. So you don't have a lot of click stops. There's still a few of them around, but I'm picking on physicians. ED physician sets a control knob to between 1 and 2. So with the click stops, if it's in between settings, okay, then the flow is 0. Okay, so the moral of the story is, make sure that it's set on 1, 2, 5, whatever the desired is there. Okay, and it's happened. Individual factors, equipment, design flaw. So a lot of this stuff is out of service, but it may be, may work at a facility where they still use it. System factors, equipment procurement decision. So that's where you see, sometimes you see the people that are acquiring the equipment will get the nasal cannulas that are the cheapest, but the tubing kinks more readily, or whatever the case may be. So it's some of the things that, just there need to be the right people at the table when these decisions to, change, the source for medical equipment or supplies actually happens. Does it work is really the question. Failure to heed package warning, inadequate training of users. Action plan, interim notification for all potential users, acquire and train on different equipment. So a lot of this stuff is the grab and go today, where you're not even have to affix regulators on them and things along those lines. Ventilator failure. So pneumatically powered, electrically controlled ventilator set up, but it's not connected to AC. It's got a battery built in. stops operating if the battery drains. Patient suffers an arrest and cerebral hypoxia. It sounds crazy, but I know of 2 cases where patients were put on ventilators that weren't even turned on. Okay, that's all I'll say. So over 30 years, only 2 cases. The good news is only 2 cases. The bad news is there were 2 cases. I'm embarrassed to say. Individual factors, human errors, system factors, inadequate vent warning system, lack of setup checklist. The list could go on. These cases can get, we could spend a half hour talking about any one of these cases. Action plan, interim notifications for all potential users, create, monitor, set up, just create a system, evaluate the system, find out how other organizations handle this sort of thing, review the literature, case this, has this happened? What was the root cause analysis there? Should we emulate that? Let's not let this happen. Let's hopefully it never happens, but when it does, that we learn from others' mistakes. We're not the ones that are actually doing it, type of deal. So coming down the home stretch here. So quality improvement strategies, some of the elements that are out there are nurse, therapist, patient-driven protocols. We have what's called an assess and treat protocol, which allows us to initiate, modify, or stop treatment, providing the patient meets or does not meet certain criteria. Evidence-based guidelines, so AARC clinical practice guidelines. Again, for you nurses, AARC is the American Association of Respiratory Care. CPG is clinical practice guidelines. My wife is a nurse, and I know that the nursing profession has these as well. Medication control, so Pyxis and profiling, BiPAP mask protocols, really talking about things for, BiPAP masks are clear for a reason. Okay, so that if the patient, obviously they're not supposed to be eating and drinking when around that, but if they do vomit, that we can readily see it. BiPAP mask protocols also, like, BiPAP patients are not allowed to have restraints on in our organization, and probably most organizations, because they do vomit, they need to have the ability to pull the mask off. So that's pretty much universal, but also masks that are less likely to cause skin breakdown and those sorts of problems. Staffing resources, in between, we've talked about different levels of shortages that have existed in nursing and respiratory care, and there's constant challenges. And some of you I know that are familiar with these waxes and waning, but right now at this particular time, it looks like some geographic areas are having difficulty in hiring and availability of staff. Standardized equipment, so not having 8 different adult ventilators, not having 4 different transport ventilators, keeping it to 1 or 2. Maybe you have a specialized one for MRI where it's fluidically controlled, non-ferrous metals, and then one for actually using the units. In some cases, they even have ventilators that can be used on multiple patient populations as well. Interdisciplinary rounds and communication, really important as well. Management by walking around, we see some of this. It's sometimes it's not funny, but it's a little bit funny. Sometimes you get these high-level people that walk into the unit because they like to say they've been to the unit, but sometimes they look like a fish out of water. I give them credit. They're trying to see what's going on around there. But we have a chief medical officer who's, by the way, very involved. He's very, very, very involved. So he knows what he's doing, and he's very, he does very much subscribes to management by walking around. Some challenges in error reduction. So you got some of the strategies you can use, but you got these constant things that you need to be aware of, the individual issues. So you have professionalism versus occupational. Profession is something that that you have to has barriers to entry. You got to get educated, you got to pass an exam, you got to get a license, et cetera, versus this is just a job. Clinical competency. So people talk around, we just had competency day. Competency is something that comes over time. Okay, it comes with experience, it comes with doing things over and over again. I'm less of a fan of having annual competency day and more in terms of having these avenues where people can readily, unashamedly, develop their competency in these high acuities, lower frequency, things that we do. Personal ethics, just valuing things like autonomy and mutual respect, things along those lines. These other system and organizational issues. Healthcare is a business, and reimbursement. If a healthcare organization is not making enough money over a long enough period of time, they will cease to exist. So there's the reality of it is, it's just that when these managers, directors, vice presidents are cutting back, it's sometimes doing that to really just so that they could stay in business. I get that, and that's something that we don't always see at the bedside. So it works both ways. Competency rather than training protocols, what I just referred to, adequacy of staffing for care and for documentation. So, all of those organizations I talked about, there's some reporting that has to go to them. Okay, somebody has to do that reporting. So it's, you need that infrastructure as well. Management's understanding of bedside issues going in the other direction. So from down up and up down. Excessive redundant documentation, which is an issue that I'm not going to drill down on this, but it's an issue. I got a paper published in 2017 on the administrative burden. It was really focused on respiratory care, but we did do some review of the literature relating to nursing, physicians, and other professions as well. Concerns with outcomes measurements. So sometimes these outcomes measurements are really good. Sometimes they're gamed. So they game, organizations may game the system in order to meet the criteria or meet the outcomes. So it's just got to make sure, are we really better, or are we just gaming the system so that we can, there was a time when there was a huge emphasis on patient satisfaction, and there was signs on a lot of hospitals: strive for 5. Ask, ask the patient how we can, what we need to do on discharge, what we need to do to be rated a 5. And there's Press Ganey. I don't know if many of you probably heard of Press Ganey. I actually have heard Rodney Ganey speak, and we had a chance for questions and answers at the end. And when I asked him about, doesn't that bastardize your whole system of doing a questionnaire? We shouldn't be saying, how can we get a 5 as someone's ready to complete the survey. It should be, we should provide 5 care, and it shouldn't even be prompted in that way. It can render the survey process invalid with certain things like that. So sometimes it's legitimate improvement, and sometimes it's gaming the system, and being able to distinguish the difference is really the key. Some of the some online resources that you guys can avail yourselves of. I do encourage you, closing note, I do encourage you, if you have further interest in this, in particular, go to CMS, Centers for Medicare Services.gov and CMS.gov. You can look at things like patient that, you have a hospital compare where they rate different hospitals. They have a lot of really good information in there, some of which may actually be helpful to your organization in terms of embracing some of these, patient safety goals, and how to actually go from point A, where you are now, to where you want to be along those lines. So with that, I want to thank you guys very much for attending today's session. Hopefully you got something out of it, and hopefully we see you again. Thank you very much, and have a great day. Bye.